So, like Miles says, I work at Haven Behavioral Hospital, and we're an inpatient geriatric psychiatric facility. So we're a psychiatric hospital, and we treat everything from anxiety to depression to bipolar disorder to schizophrenia. And then we treat patients that come in with dementia and are having some behavioral expressions, oftentimes that come with patients that have dementia. So when you come into our hospital, your average length of stay is about 10 to 14 days. And it's not a long-term care facility. It's just to come there and get better and hopefully leave a little bit better than you came in. So we're going to talk about depression in the elderly today. And just to give you a little bit of background on me and why I give this presentation, I've been doing business development and marketing for about 20 years. And inclusive in that is I've been often hired as a consultant to sit in on contract negotiations, to pick up on the psychology of people and to figure out how they're going to vote on things, what their body language is, to try to figure out if we're doing the right things, if we need to offer the right things, which is kind of a unique position to be in. But what gives me that unique position is when I was a senior in high school, my dad, who is an untreated bipolar patient, caught himself on fire. As part of his illness, very, very manic. And so I made it my mission to become as educated as possible on depression, bipolar disorder, anxiety, any things that were affecting my dad at that time. Then I became a crisis counselor for lots of different demographics, for children, adults, and adolescents. So along the years, just being able to interact with people that have challenges with mental illness, specifically depression and bipolar disorder, I think has made me pretty well versed. I wouldn't go with an expert. However, I don't know how you get any better experience than living it day to day. So now being at the psychiatric hospital is perfect for me. It's absolutely the best thing I've ever done. It's a great fit. I get to watch families come in that are nervous and scared and sometimes guilty about walking in the doors, and I know exactly how they feel. So for me, it's really kind of giving back. So before I get into the meat of the conversation, you're all caregivers? All of you? Okay. At this point right now, do you think that there's anyone you're taking care of that might suffer from depression? Yeah? Okay. All right, so we'll get right into it. We talk about depression in the elderly. It's not entirely different than just depression in you or I, but there are some different things that happen that we want to take a look at. Probably most of us don't know that depression in the elderly is fairly rampant. So about 6.5 million of the 35 individuals ages 65 and older are touched by depression, which is a pretty big number. Depression affects approximately 25% of individuals that have issues such as heart disease, chronic illness, high blood pressure, stroke, Parkinson's, lung disease, and 50% of those of the ages 65 and up who suffer from depression are in a nursing home, which makes your job even more important because we'd like to keep people out of nursing homes. Of course, we like to have folks in the hospital if we can help them, but our goal is to try to keep people at home as often as possible because that helps with depression. Having your own surroundings, being cared for by people that you love, that are friendly to you and that they're familiar to you makes a big difference. So what's the difference between being sad and depressed? Do you guys know what the difference is?
Things that last for just a little while, then you pass and go on forever.
That's true, that's true. So when I say depression, what do you think of when I say depression?
Sleeping.
No, please, go ahead, whatever it is you think. What about you?
Insomnia,
Mm-hmm.
burst crying,
Sure.
can't function, daily functions.
You hit it right on the head.
And then it goes on
So all those things you discussed and you said are absolutely right, and we'll talk about those symptoms, but I want to give you a really good idea of the difference between being sad and being depressed. We all get sad. Sad things happen. We lose jobs, we lose loved ones, we have financial issues, we lose a pet, we have job issues, we all get sad. But usually after 2 weeks, we've kind of moved on from that sadness and it's not debilitating to us. Even if we lose a loved one or a pet, a normal grieving period is about 2 months. Now that's not saying people don't grieve for years. Of course you do. But 2 months of not being able to sleep or eat or having really some problems functioning is about normal for a grieving period. Now, 2 weeks with nothing that's a situational issue, meaning nothing that happened, you've just started to feel a little bit different. If you feel helpless and hopeless and sad and crying spells and having a lot of the symptoms we're going to talk about for 2 weeks straight, that's enough to have a diagnosis of clinical depression. That's not going to go away on its own. If you have clinical depression, you can't just pretend it's not there. You can't act like it's going to go away. Once you've started in that downward spiral in that hole, it's just going to get worse. So let's talk about some symptoms of depression in older adults. So when I asked what depression was, you guys started to give me some symptoms. Those are pretty traditional and typical symptoms. Can you think of anything else that might go on when an individual is depressed, anything that you could see, or if you know someone or you have intimate knowledge, what are some symptoms?
Maybe like constant worrying.
Yeah,
about things.
that's right. Anything else? We see some very interesting symptoms in older adults. So oftentimes we'll see constant need for help. And when I say need for help, I mean things that your clients and your family members would do by themselves all the time, but all of a sudden they can't do it. I can't do the dishes. Quite frankly, I can't do the dishes a lot too, but that's just because I don't want to do them. But normal things, I can't get my clothes on, I can't make coffee, I need you to do this, I need you to do that. Specifically, you guys might notice it if you have clients that are calling all the time. Miles, I need you to come here right now. I need help with this. I can't do this. I can't do that. Things that normally you wouldn't get a phone call to do. Weight, gaining weight, losing weight. Oftentimes if we think people are depressed, they're just losing weight and they're sleeping all the time. But the fact is people gain weight and people have insomnia. They either can't sleep or they can't sleep enough. Other things are worrying. Absolute worrying constantly. Something's going to happen. You walk out the door and something bad's going to happen, or you have a client that tells you, well, I know this is going to happen and I know I'm going to get sick and I'm probably going to die pretty soon. All these different things are going on. So again, I'm not talking about, oh, I'm just a little bit sad. I'm talking about some statements that are coming out that are pretty serious and quite frankly at times can be a little bit delusional. So I say delusional and everybody probably thinks, oh, delusions. People are seeing things or hearing things. That's not what I'm talking about. Sometimes what we see in a depressed elderly patient is called somatic delusion. That's a kind of a big deal. Do you guys know what that means? It was a lot along the lines of what I was just talking about, of thinking that you're sick. We see that with elderly patients all the time. Well, I know something's wrong with me. I can feel it. I feel it inside of me. Something's very, very wrong. Well, maybe there is something wrong. But when it's an everyday kind of thing, we kind of question that a little bit. Memory problems. Stress causes memory problems. Who's been stressed here and then you can't remember anything? I certainly have. Yeah. Everyday things you forget. Feeling worthless, fidgeting, crying spells, thoughts of suicide, verbalizing thoughts of suicide. And I cannot hesitate or tell you enough that if someone tells you they're going to commit suicide or they're even thinking about it, or they just even mention, you know what, I'd be better off, do not hesitate to pick up the phone. I don't care if that person has said it 20 or 30 different times. It takes one time to say it and one time to mean it. So we never know. Excessive worrying, we already talked about that. Help seeking, neglecting responsibilities. So this is a pretty serious one, although it might not seem like it. I was kidding about not doing dishes, but sometimes when you're depressed, you don't do anything. And it starts out very slow. Maybe you're not doing the dishes, then all of a sudden you're not picking food up that's in your home, you're not grocery shopping, you're not taking care of yourself, you're not showering, you're not doing your hair, and then you're not taking your medication. And that's what we see oftentimes in older adults is they stop taking their high blood pressure medication, they stop taking their heart medication. If they had been on antidepressants or any other medication like that for a previous diagnosis, they're not taking those medications. And we know as caregivers that that's deadly right there. That's something that we call passive suicide, right? It doesn't mean that I'm going to tell you, you know what, I'm going to kill myself or I don't want to live. But what I'm going to do is I'm going to stop taking all my medications, not because I'm trying to kill myself, but because I don't care anymore. I don't care about living anymore, so I'm just going to stop. Withdrawing from social activities, so that's a great thing to look for. If you have clients that are out and about and they like to go out and they like to take a walk, they like to go to the library, they like to play cards, they're social. And then all of a sudden, they're just not social and they don't want to be around anyone at all. That can indicate a couple of different things. There is kind of a unique set of circumstances between someone that has the beginnings of dementia and someone who's depressed. We'll talk about that a little bit more, but that feeling and that isolation is also something that happens when someone first starts to feel or understand that they're having symptoms of dementia. They start not wanting to go out because they're afraid that someone's going to catch on to it. They understand that they start saying things differently, their memories are a little bit different. Maybe they're losing a little bit of filter and they decide not to go out at all. A little bit different than depression, but they kind of hit hand in hand. So we talked about, and feeling slowed down. You know, if anyone in this room has ever experienced depression, you don't have to tell me if you have or not, but you can understand that all of a sudden things start to just be overwhelming. I don't want to go down to the mailbox. It's just, I don't have the energy to get down to the mailbox. Then I don't want to pay my bills because now I have to look at everything and figure out how much money I have and I have to do finances. And you know what? I know I need to get my kids here and there, but I can't get them there. I just don't have the energy to do it. I don't want to get up this morning, and so I'm going to make excuses why I can't do everything else, and that's going to affect everyone else around me. Lots of different things to look at. We don't all have each one of these symptoms, and your clients aren't going to have a whole laundry list of all of these symptoms, but they're going to have a couple of them for sure. So what causes depression in older adults? Now I'm blind. What causes depression in older adults? What causes depression in anyone?
Yeah, illness could be illness, it could be
Yeah.
their aging,
Right.
injuries.
Losing friends and family.
Yeah.
Sure, absolutely. So when we get a little bit older, we start losing friends and family, and we lose our best friends, and we lose our loved ones because they're getting older too. And all of a sudden, it's not just one person. Now it's like 2 or 3 or 4 people that you know that are passing away. That's devastating. It's very difficult. Disability is one. Having an illness that causes you to be disabled. How many of your clients, when they first are looking at home care, decide that they don't want anybody to come in and help? Lots of them, right? Yeah, because they don't want to lose their independence. And once you have a very disabling disease or illness, somebody has to come take care of you, and nobody wants that. I don't like people in my house. I'm terrible when I'm sick. I'm the worst patient ever. I just want to take care of it and do it myself. Like your boss there, who remains in a sling.
They still want their space.
Well, yeah.
They're more independent and they only want you when they need help.
Yeah, that's right. And you don't want to feel like you have to rely on everyone to get things done. That's hard for just anybody, but to know now for probably the rest of your life at where you are right now that you are going to have to rely on people and you are disabled is something that people have to live with. And sometimes you can do it and sometimes you just absolutely can't. Retirement, people are busy all the time and then all of a sudden they're not doing anything, especially people that don't have hobbies. They haven't had any hobbies before. Work has been their entire life and now they don't have work to go to. We're going to start seeing a very, very interesting pattern when people from the labs start to retire. Do you know why? We're going to have people from the labs that are very high functioning. We're going to have some Asperger's that's probably there now in the labs, but we don't see it because people are using a different part of their brain and doing some strategic functioning. Once those folks retire, we're going to start seeing a lot more people who are having some depression and some other behavioral health issues because they're not using that part of their brain anymore. And it's going to be something to look for.
That's really interesting.
Yeah, I mean for you, both for your jobs and mine, for sure.
Exactly.
Change in living situations. How many people have to leave their home and go into an assisted living? Or they have to leave their home and go to an independent living because they just can't keep up with their house anymore. That's difficult. That's hard for anybody.
They leave the state to come live with their kids.
That's right.
Everybody they know, all their friends
Yeah.
are gone.
That's right. And we go back into that we're disabled and we're dependent on people. We don't have our own space. Side effects of medications. You guys, I know for a fact you have clients who have 20 medications, 10 or 20 medications. You open up their pill bottle and it's full. Well, so not all those medications taken at the same time are a great idea. And unfortunately, because of a lack of communication with physicians and pharmacists oftentimes, we've got medications that are just reacting to one another and they're causing depression, which is unfortunate because you don't need to live like this, but you need to have someone who's responsible enough to be taking a look at those medications to make sure that they're not, sort of canceling each other out and causing a different problem. Biological factors, well, here's the thing. Sometimes it's in your family and it's genetic. Oftentimes that's going to happen, and I'm not saying it has to. Just because you have a parent or a brother or a sister or a grandparent that has depression, that doesn't mean you're going to get it. However, it's a good idea to take a look at yourself and also your clients, what's been going on with them. And I speak from experience. I've got 2 cousins who are schizophrenic, and I have a dad who is bipolar. So quite frankly, I look very close at me and how I feel. I watch my children to see how they feel, and I look at other family members around and my family member's kid, because when I go and talk to them, they're always like, "Are you analyzing me?" I am probably. Unfortunately, I probably am. But those are factors to keep in mind for your clients. Do they have other family members that go through this? Because that's a big telltale sign for sure. So why does depression in older adults go undertreated? Why does depression in anyone go undertreated?
People don't speak about it.
Yeah, I don't want to talk about it.
Yeah.
Still a pretty strong stigma about mental illness, right? Even we talk about Robin Williams, and that's a very sad thing. But quite frankly, you look at a man who was very famous and wealthy, and in all appearances had a beautiful family and everything was going on, but suffered from depression for a very long time. I don't like that happened, but I do feel like now the American public has a different understanding of what mental illness looks like. It doesn't discriminate. Depression doesn't discriminate between young and old, male or female, black or white. It just doesn't matter. It happens. So depression in the elderly sometimes goes overlooked because number one reason is we think once you grow old, you're supposed to be depressed. When you're old, what happens? You're senile and you're sad and you're grumpy. That just happens. That does not happen. And you know it better than almost anyone because not all of your clients are old and grumpy and sad. I'm sure some of them are. Some of them have been grumpy forever. They're just going to be grumpy folks. But just because you get old doesn't mean you're sad and depressed. Many health practitioners and family members don't even know what depression looks like. Seems like a pretty simple thing. But oftentimes, let's say I go into the doctor and I have all these other issues going on and I don't mention that I'm feeling depressed or sad, a doctor's not going to all of a sudden be a mind reader and say, you know what, oh, Leah's sad. I can tell she's depressed. Because I'm coming in to get my blood pressure checked and I'm coming in to do some other stuff, and then you're going to ask me, well, how are you doing, Leah? And I'm going to say, I'm fine. I'm fine, right? I'm sure you see this all the time.
Sure, absolutely. And you know, once you get done with the 5 or 6 things they came in for physically,
Yep.
you've got other people waiting to see you.
Right.
You don't have necessarily have to have that time.
And if someone doesn't bring it up, it's not necessarily you're going to ask.
Not unless it's just blatant.
Right. So here's something we're trying to change the face of, is that we would very much like practitioners to add that into their repertoire of questions they ask elderly patients. How is your mood? Tell me how you feel today. So it's not necessarily I'm fine, it's how is your mood? My mood is this. Because again, stigma. There's stigma. And essentially with this population we deal with, nobody talks about mental illness, right? Even back when they were young, they're eccentric, they're hell raisers, they're, they spend a lot of money, or they're just melancholy and sad. It's not meant people are mentally ill. There's all these other things. So no one talks about that at all. This is one that blows me away, and it wasn't until I started working at the hospital that I understood this. We have patients that call all the time that think that they can't afford to come in and get treatment. It's too expensive. It's very specialized and it's very pricey. We're a hospital, just like any other hospital, except we treat mental illness. But insurance covers what we do. Medicare covers almost everything that we do. Medicaid covers what we do. It's no different than going into the hospital if you're having a heart condition. It's paid for. Yet so many people and families will tell me that, well, I really would like to come in and get some help, but I just don't think that I can afford it. And they think it's all private pay, which it's not. That's a big deal, because none of us have a lot of money right now, and so paying for something very special that's not covered under our insurance is probably not going to be the first thing on our list that we're going to do. Misdiagnosis, and we talked about this a little bit, but depression and dementia look a lot alike in the beginning. Lots of similarities. We talked about the isolating behavior and the memory skills, the lack of memory. Those things look very similar. So oftentimes physicians as well as family members are more apt to think, oh, well, it's dementia because someone's older. We wouldn't even jump right into depression. We think, oh, dementia. They're stressed. They don't remember anything anymore. They're staying in the room. They're isolating. They're confused all the time. We don't stop to think that dementia is a very specific thing. Depression is a very specific thing. So without asking those questions and going down the line of, do you have this? Are you experiencing this? How about that? You're not going to know. You're just going to assume one thing is the other.
Oftentimes, though, you ask that question if they're going through depression and stuff, they're gonna get angry with you because they don't want to think about it. They don't want to, and they're upset that somebody, caught on. I know my folks were like, "Oh, don't ask me."
Did
Don't talk to me."
your parents have dementia?
My dad started out with dementia. My mom was, I think, depressed. She swore up and down she wasn't, and she was mad at me all the time if I asked.
We're going to talk about that in a little while, because when I touched on asking people how they feel and they say fine, we'll talk about that a little bit.
I imagine also there are some diagnoses some diseases you might have that interfere with your ability to express your depression. Like certainly dementia is one
Right.
where you maybe are a little bit aphasic and you can't really tell people how you feel.
Parkinson's.
Parkinson's, same thing.
Yeah. Yeah. People who have strokes, oftentimes.
Exactly.
I mean,
There's
that's-
reason to be depressed.
Well, yeah. Not only just physiologically and mentally, but you have a stroke and things change for you. So I don't know if I'd mentioned this to Miles, but I had a stroke 3 years ago. I had a tiny TIA. Yeah. And so for me, I'm obviously very high functioning, but the fact of the matter is when you do have a stroke like that, for a little while it takes you time to get some things back. Took me a little bit of time to get some speech back, to be able to function totally normal. And I felt sad during that time because I thought this is going to change my life tremendously. but quite frankly, all it did was change my lifestyle. It didn't really change too much about me, but that's scary. And I don't think I went into the doctor and said, you know what, I'm feeling sad about this, because I just thought, well, I am sad about it. And it didn't last a long time. So I knew. But things like that, you're absolutely right. People can't express how they're feeling, or they think that it's normal how they're feeling.
Sure, they wanna-
So what happens if depression goes untreated? What's the worst thing that could happen?
Suicide?
That is kind of the worst thing. So we talked about this a little while ago. It's common for people that have depression to stop taking their medications. And that's a big deal, especially in the demographic we're talking about. It can double the risk of cardiac disease and increase the risk of developing other serious health conditions. And it can increase the risk for rapid cognitive decline. So if you're already starting to experience or see some beginnings of dementia in your clientele, someone who's depressed, that goes a lot quicker. And then suicide. These statistics for suicide in older adults is absolutely frightening to me. So someone who's 85 years and older is highest of all, twice the average national rate of committing suicide. Before a depressed senior commits suicide, 20% of those see the doctor the day that they die. That number alone is why we are trying to educate physicians on asking those questions beforehand. Think about someone just walks into the doctor to go and get their blood pressure checked or have some very basic needs to be checked, and then they leave and they kill themselves. They haven't even mentioned anything. 40% see the doctor the week they die, and 70% in the month they die.
Why do you think that is? It's some kind of like asking for help without
Yep.
asking for help?
Exactly. That's exactly what it is. So people will go into the doctor. Maybe they have some valid reasons to go. You know, maybe they do need their blood pressure checked, or maybe they need their heart medication changed. But maybe it's not those. Those are not emergent situations, but they go in hoping that someone's going to ask them, what's going on with you? How do you feel today? Because chances are they're not going to ask. So we'll talk a little bit about treatment options. Depression is the easiest form of mental illness to treat. Easy. Schizophrenia, not so much. You're not really going to help schizophrenia. You're going to really sort of just soften what happens with schizophrenics. You're going to help them to be able to function with their visual and their audio hallucinations. But with depression, somebody can walk out the door and, you know, take their antidepressants or do some different things, and in 4 or 5 weeks, they can feel fine, absolutely fine again. We don't know any other typical mental illness that can happen with. This is fantastic. So let's not let some folks fall through the cracks when it's so easy. So I'll talk about the natural options first, because I'm not a big fan of taking medications. I feel like you have to start here first. And a lot of people don't want to take medications, and a lot of people, again, our demographic that we deal with, take hundreds of medications. So adding a new one on is sometimes never a good idea, and people don't want to do it. So social support, wow, that's a huge one. So people who stay at home and they isolate themselves and they don't have anyone else to talk to, they're going to sit with their own thoughts. They don't have any socialization. And when I say social support, I mean things like going to a senior center, playing bridge, playing cards, doing something with other people. There's a study that was out, and it showed that doing an activity makes your brain, your neurons pop. Doing an activity with someone else is fireworks. Makes a big difference.
Where have you never been the kind of person that really pursued social activity? I mean, you're trying to fit a square peg into a round hole. that
Right.
way.
And you can't force anyone to do this. You can't. But you know what you guys are doing by being there? You're already social activity. So, which leads to the next thing, you need to be doing something. If you do have the opportunity to be with your clients who are starting to isolate and you feel like might have some symptoms of depression, do something with them, because then it's not really them being out and doing something social. It's like, oh, well, this is my caregiver and we're here doing this. And of course, that's what we do. It's like a trick. You're tricking them. Diet makes a huge difference. Processed foods are no good for anyone. They just really aren't. We look at different things in the hospital. We have a dietitian that comes in and looks at everyone's diet and makes our menu very specific, not only to cover diabetics or mechanical diets, but to really look at the fruits and vegetables and the minerals that are coming in. Taking out processed foods, taking out heavy starchy foods, and looking at blueberries and chocolate and vitamin D and vitamin E, and really trying to change things in someone's diet, taking away caffeine, sugars, taking away anything that's not a natural sugar. And I'm not saying we're Nazis about the diet, but we're saying there's very, very, very specific things that you should be eating and very specific things that you should not be eating. And like we talked about earlier, sometimes when we're depressed, we eat more, and so we put on weight. So trying to look at that on an individual basis and figure out some things that we can put into someone's diet, so if they are eating more, it's not going to make a significant weight change. And vice versa, for patients that don't eat or choose not to eat, we have to look at that too. So really kind of doing some carb loading without using a lot of excess sugars. Exercise, man, we live in one of the prettiest states in the world, I think. Sometimes I just walk outside and take a look and take a walk around, and I feel 1,000 times better. We do that at the hospital all the time. We go outside, we try to make an effort to just walk around a little bit. We get the brain going, we get the heart pumping, we get fresh air in. How many of your clients just stay inside all the time? All the time? Is it because they don't want to go outside or they can't?
Yeah.
They don't?
Yeah.
So
I joke with one of my clients, I tell him it's time to do your push-ups.
nice. Nice.
He does his exercises too and stuff, so.
And you make a great point there. Exercise doesn't mean that your clients are out jogging a mile, or they're at the gym, or they're doing push-ups, or they're doing, Zumba. It could be some chair exercises, right? Just some very basic, maybe some teeny tiny weights, or even some stretching exercises. That makes a big difference. Maybe it doesn't seem like it, but even doing something light and getting your heart rate up just a tiny bit, or breathing just a little bit more, really changes those endorphins in your head.
Walking around through the house.
Walking through the house, if you can get someone outside, even if it's to walk to the mailbox, baby steps. Oh, today we walked to the mailbox. Tomorrow, we're gonna walk maybe up to the end of the street and back. Tiny things. People are gonna be resistant. When people are depressed, they don't wanna go anywhere and do anything. But then you're there, and you're kind of the first line of defense sometimes, so thinking about little things that you can do. Let's go out and look at the flowers. Let's go look at the sunrise. Let's go look at the sunset. Let's go look at the moon. You guys check out the moon yesterday? That was fantastic. It was beautiful. Sleep. We should all try to get 8 hours of sleep. I'm pretty sure I don't. I know for a fact Dr. Nelson does not at all, just because of what we do for a living. I'm sure all of you probably don't get as much sleep as you should, ever. People that are depressed really need that scheduled sleep, because again, we're looking at folks that are sleeping all the time and folks that are not sleeping enough. So really trying to have a routine down of, I'm going to go to sleep at 9 o'clock, or I'm going to go to sleep at 10 o'clock, and then I know I'm going to wake up at 6 or 7. This is what I'm going to do. This is when I'm going to wake up. And even to add a little bit something to that kind of goes right into routine is, all right, Mrs. Jones, let's go to, maybe it's time you want to go to bed now because we've talked about this. And when she wakes up at 8 o'clock, you know what? Let's do the dishes. And every day, have a routine like that. First thing you do, you're going to get up and make the coffee and then do the dishes. So that means when someone wakes up in the morning, they know they have some very specific things, even tiny goals that they have to get done. And accomplishing those 2 tiny things will be fantastic. And then you can add a different thing on in the morning. But that is a structured routine of, when I get up, I automatically am going to make coffee. I'm automatically going to wash the dishes. I have something to do. I have a purpose in the morning.
We've had multiple clients that their primary diagnosis was depression, and that's why they hired us. And one in particular I recall, she had trouble just getting up in the morning and getting things going, and so we went in there, and I said, okay, your caregiver's gonna be here at 10 o'clock, you need groceries, you have a homework assignment, you need a grocery list, so make a grocery list, and then you go grocery shopping. And that really, was compelling for her. She's like, oh yes, good, now I have something to do.
Right. It's an assignment, it's a task, and it's not a huge task. It's one that's very doable. Writing a grocery list is perfect because you know you need groceries, first of all, and writing a list is not too taxing. That's a great start, just even little things. Or make me a list of things that need to be done around the house. Because you're going to be there, you know that there's things that are going to be done, but you don't know in that person's mind what they would like done today. So ask, hey, I'm gonna do these things and let's start breakfast, but could you make me a list of things that need to be done around the house? That's a great example. Volunteering. So if you do have a client that's ambulatory and up and about and they are suffering from depression, again, when you're depressed, you don't want to do anything. You darn sure don't want to be about a bunch of people. But I guarantee one time of getting someone out and helping somebody else, I would put that against antidepressants any day. Going out and doing some type of volunteer item, whether it's reading to someone, whether it's going to a facility and just helping with food or talking or playing pool with someone, serving lunch, doing something for someone that needs your help more than you do right then really gives you a perspective of, you know what, wow, I don't feel that great, but this person doesn't feel that great, and look what I did. I made somebody's day. I made someone feel better, and I'm worthwhile. I'm a worthwhile person because look, I made a big difference today. That's an easy way to make a difference for anyone. And then laughter. So I will be so angry with my kids for whatever reason, and they know, unfortunately, that if they make me laugh, I'm done. Like, I'm done. They can do all kinds of stuff, and then they'll make a joke out of it, and I'm like, all right, fine, that's fine. And then my whole mood changes. Don't hesitate to go get a funny movie. And you can get one that's period appropriate for your client. You can get one that you just find is really funny. I mean, I caution you to, not make it too colorful if that's not what your client likes, but there's nothing wrong with that. Just putting on a funny movie, even if they're not sitting and watching it, there's that laughter and that sound and those senses that eventually they're going to catch on and they're going to feel good. And then all of a sudden you want to laugh. Because when you're depressed, you more prefer to watch something really sad that's going to give you the ability to cry and get out emotions that maybe you can't normally get out than watch a funny movie. So if someone puts a funny movie on, you're almost forced to listen and watch it, which is very simple. So medications, if none of those things work, which I'll be quite frank, those things they're all good. But sometimes if it's clinical depression, someone's going to need some additional help. Clinical depression is an illness. It's not just something that someone made up. It is an illness like high blood pressure, like diabetes. It is something that has to be treated. You cannot ignore it. You have to deal with it. So there's medications, there's antidepressants and anti-anxiety meds, and I could go through the whole gamut of them, but everyone would be bored with that, so I'm not going to. I'm sure you've seen your clients take them. Now, something that I'd like you to be aware of, and maybe we can do some extra education on this at some point, is I see clients all the time that come into the hospital that are taking 2 or 3 antidepressants or 2 or 3 anti-anxiety medications. And it doesn't work that way. You don't need to be taking all of these medications for one issue. What we do a lot at the hospital is we take people off their medications first. We titrate them down just to get to a baseline to see where people are and then add something that's appropriate. We had a lady come in, I'd say a couple of months ago, and she was on 4 antidepressants, 2 mood stabilizers. She was on a lithium and a Lamictal, and then some benzodiazepines. I don't even know how she was functioning. I don't know how she was walking and talking. And so without you guys being pharmacists, but if you do medications, do you fill med bottles and pick up prescriptions? It's always great to kind of have an idea of what those things are for. So if there is an issue, you can call your care coordinator and say, you know what, Mrs. Jones is taking this, this, and this, and they're all for depression. Is that, can we find out if that's okay? And of course, Dr. Nelson's going to be able to look at that and say, oh, that's kind of questionable. Psychotherapy.
Before we move on from medications, the point I'd like to make, and you've got more current thinking on this than I do. A lot of times when people are really depressed, like you said, they're slow weighing down and stuff, and not often, but sometimes when people are placed on antidepressants, they get more energy, and they might be more apt to act on their suicidal ideation.
Yeah, that's right.
So there's a little bit of a danger time when you start your antidepressants until they kick in 3 or 4 weeks, and you're homeostasis at that point. So you need to be more aware of behaviors that might, and verbalizations that might indicate that they're actually thinking about acting on their suicide thoughts.
And that's right. When we start someone on antidepressants, it usually is about a 3 to 4 week period before you really see anything. Although it does start to make people feel a little bit better enough to maybe do some things that they wouldn't have done.
Right.
We have to worry about that a lot with our bipolar patients because that is a whole science in and of itself. You have someone who's coming off of a deep depression and you want them to get out of that, but at the same time, you don't want them to be manic either because most bipolar patients who commit suicide do it in their manic phase. So you have to be real careful about that, and that's the same with traditional depression too. You want someone to pull out of the fog, but you don't want to pull out of it too quick so they're making bad judgments. Psychotherapy is very important because if you just give somebody medications and you don't allow them to talk to you about what's going on or help them to figure out what's going on, you're just putting a Band-Aid on an issue that, quite honestly, is not ever going to go away. So if I have some really deep-rooted things or I've had some things that happen to me and I don't necessarily know that that's what's making me depressed, but if I start to talk to someone and I feel like, wow, I do feel better about talking about this and I got this thing off my chest, that's huge. That's a big deal. If you're just giving someone medication, maybe they forget about it, or maybe now their chemicals in their brain start to just sort of move on, but that's still there. That's never gone away. And so without talking those things out or really trying to do the work to figure out what's going on, medication in and of itself is going to be a very quick fix. So when I say ECT, what do you think of? You know what ECT is? Except for Dr. Nelson, he can't answer this one. Electroconvulsive therapy. When I say that, what do you guys think of?
Shock therapy.
Lobotomies?
That's what people think of. People think of One Flew Over the Cuckoo's Nest,
That's exactly what I was thinking.
where everyone's getting shock therapy, and it ruins people, and it essentially lobotomizes people without the surgical process.
But it's different now, right?
ECT has always been a great therapy for depression for folks that when medication and anything else didn't work. And we are talking severe depression where nothing's helping. But yes, it was overutilized in the past and not utilized appropriately. It gave it a bad name. Somebody said the other day when I was giving this discussion, oh, it's back in vogue, it's vogue. Well, it's not vogue. It's not a new thing that people are just, oh, we're going to do this for a little while. It's a great treatment. And the treatment essentially uses electrical currents to cause a tiny seizure in your brain, which essentially clears the slate on the chemical issues going on for a short period of time. You don't just get one treatment of ECT and then you're fine. You have to go back for periodic treatments. But for people who cannot respond to medication, this has been shown to be very, very beneficial.
It's all voluntary, right? It's not,
What do you mean?
voluntary means if you want to get it, like in the past, they said that, they
No,
would.
we're not forcing anyone into
Yeah, well, that's
ECT.
what I'm saying.
No, you're right.
Yeah.
Do you guys do this at Haven?
We do not.
Okay.
But we do send folks out to UNM on occasion if we feel. I can think of maybe 3 patients in the 2 years we've been open that we've sent someone to ECT because we hate for someone to leave our hospital and we can't do anything for them.
Yeah.
But sometimes we can't do anything. And I think we're good enough at what we do to be able to say, this person needs something different. And so, of course, we give the patient the option. We're not just sending them over there and saying, you're going to get ECT. So generally someone who hasn't been able to benefit from medication and they're still in that deep, dark depression and fog wants to do whatever it takes to feel better. TMS is a new treatment. Are you familiar with this, Dr. Nelson?
Yeah, I am.
Okay.
I think, Sage does that.
Sage does it. So we work really close with Sage Neuroscience. So what TMS is, instead of using electrical currents, it uses magnets. And it's non-invasive. You don't have to take any other medication. You're not having to be sedated for this. Essentially, you sit in a chair, you're very relaxed, and you have a magnet who moves around. You have to have several treatments of this too. It's not just a one-time treatment. I think it lasts about 37 minutes for the treatment, and then you're up and you're on your way. There's no problems, no issues at all.
How does that work?
I don't know how it works, to be
I
honest.
looked it up once and I forget what I
Yeah.
I got introduced, I saw the machine at Sage and I was like, really? And I looked it up and there's no science behind it. I forget what the science is though.
Medicare covers that.
I know.
There's got to be science behind it if someone's going to cover it. Well, I mean, we would think so, but it's been proven very beneficial. People who don't want to go the route of ECT because they are still just deathly scared of that have started this, where we've actually referred 4 or 5 clients for this already and have been very excited to not have those clients back.
Really?
Yep.
Okay.
It's a big deal. So for us, anything like that where it is a non-medication treatment and someone's going to have this done and they're very relaxed and then we don't see them back, that's a win for us. Win. We like treating patients, but as I mentioned, we don't want to see you guys back if you don't have to. We would prefer you not come in. We prefer people stay home and get better. But if you need to come to us, then that's fine. So our patients are being able to benefit from that. It's very exciting for me. It's very exciting for the hospital. Sage Neuroscience does some really fantastic things and we work with them very closely. So we're very lucky to have that. So getting help. Nobody wants to try to talk to someone about depression because a lot of times people are angry and they don't want to talk about it.
Or they're in denial?
A lot of denial, but mostly a lot of people are embarrassed too. They don't want to say anything. This puts you in a very unique position because your clients are going to tell you things they're probably not going to tell their family because they don't want their family to think they're crazy or they're sick or they're this or they're that. And so they're more likely to confide in you about how they're feeling, and you're going to see things because you're going to be there, repeatedly on a schedule. So you're going to see things maybe that your client did today that she didn't do yesterday, and now she's not doing this and not doing this because you're going to be there every day, or at least in succession. So that gives you a little bit more of a responsibility too, to try to pick up on these signs and symptoms.
The other thing is you don't have the baggage that family members have.
Right. Yeah, absolutely. If I'm depressed or I'm bipolar, chances are I've really affected my family's life. And maybe it's not in a good way. And maybe my family at this point either thinks I'm crying wolf or they really don't want to help me. I mean, it's a sad truth, but we see that all the time in the hospital. People have diminished their relationships with their families because of mental illness. So that again puts you in a very, very important light. If you suspect any of your clients of having depression or see some of the symptoms that we talked about, going to a physician or recommending to their family that they see a physician, or however the chain of command goes, that's the first thing you want to do. Absolutely first thing. And then if you can be there, if you can coach a family member into having someone go so they can say, well, you know what, Mrs. Smith, I have noticed that you're sleeping a lot and you seem to be really sad. That's an easy way of not tattletelling, but sort of just helping along the situation. And then the physician can hopefully carry on that line of questioning, understanding, hey, there is something a little bit different going on. But that's a big responsibility because people aren't going to want to go to the doctor for just being sad, oftentimes.
Yeah.
So one thing I would say is don't overestimate the ability of a physician to kind of get it and figure out if you're trying to hint
Yep.
along a certain line of questioning. You need to actually say words to them, like maybe outside of the client's, earshot. I think they're depressed, and so that you're actually addressing the specific issue rather than having the client go, yeah, my foot hurts and my calf's acting up and I'm feeling this way, because they'll do it. They try to keep the spotlight off of the thing they're scared of.
And that's right. Using that word, just saying depressed, I don't say that very often because I know that patients sometimes can be like, no, I'm not depressed. But really, if you give that buzzword, that's a big deal. And the doc's going to pick up on that and think, all right, now there's some other questions I need to look at, things I need to look at. If a physician says, yeah, you know what, I do think this is depression, ask for a geriatric psychiatrist. The reason I say that is because, however, you have a fantastic physician here who deals with geriatrics and really, I think, has a very good grasp of mental illness in geriatric patients. Not everybody is as great as Dr. Nelson. So ask for a referral and tell the family, you know what, there is such thing as a geriatric psychiatrist. Who knew that before I came in today?
At what age would a person be considered geriatric?
Well, I don't want to scare anybody here, but our hospital considers geriatrics 50 and up.
50?
Mm-hmm.
Wow.
55 is really the standard, but we see patients. We see patients that are 50 and up. We'll kind of look at that, a 50 to 55 patient, if we feel like they'd benefit from treatment with the other patients that are on our unit. Just makes a difference. If you're a 50-year-old, 210 psychotic gentleman, and I've got some 60 and 70-year-old ladies on the floor, you might fit into our age criteria, but I'm probably not going to bring you in. But to go see a geriatric psychiatrist, I would say probably 55 and up. You can make an appointment with whoever you want. They can always tell you you're not old enough for me.
You just get your ARP card in one hand.
Right? You just walk in with your AARP card, you're like, hey, I need you. The reason that we suggest a geriatric psychiatrist is because they're looking at all those other comorbidities, meaning they're looking at all the other things going on with this patient. What medications are they on? What are they being treated for? And then looking at normal progressions in aging as well. So being able to understand what the differences is between the normal progression and looking at some mental health issues. We have patients who have who are bipolar and they're demented. We have patients who have schizophrenia and they're demented, and we have patients who are severely depressed and they have dementia. So trying to solve that puzzle is a little bit more difficult than you coming in with just depression. So we have a geriatric psychiatrist who has a very good solid grasp on what dementia looks like and what depression looks like and how they fit with each other and how they can be treated. Very, very different from you and I. Our metabolism is very different from older folks, and so the medications that are going to be prescribed are going to be very specific doses and very specific types of medications. If I'm not eating, I'm probably going to get a medication that's going to stimulate my appetite, but not really affect with my other medications and not make me catatonic. It's very easy to overdrug older adults. Very simple. We see it all the time. So ask for a geriatric psychiatrist. There are a few here in Santa Fe, right? Dr. Camp, I believe. We got a couple here. Be sensitive and compassionate when you're bringing this up, whether it's with your client or with the family. And I mean it. If you're not compassionate and if you don't have any empathy about this, do not have that discussion. Talk to somebody else so they can have the discussion. I'm not saying anybody in here is a bad person. I'm saying that it can be because of family history, because of anything else that's gone on. If you really don't think you can have this discussion and make someone feel comfortable, don't do it. And offer reassurance. You don't have to feel this way anymore. I've seen you every day and you're crying every day, and I know you're so sad, and you don't have to be this way. This isn't the way, this isn't normal. You don't have to feel this way. And let's go get some help together. Let's do this together. Mm-hmm.
This makes me think of a caveat. A lot of what we do is hospice support. And as people are going through that process, there's a depression aspect of that as well. And I'm very clear with the caregivers, your job is to do active listening, not to say you don't have to feel like this anymore because you do, because you're dying.
Right.
Can you talk about that?
Yeah, absolutely. So that's different, but absolutely. So someone that's on hospice, whether it's the hospice patient or the family, that is the thing. You're not going to change what's happening with them. So you do want to listen, and you do want to be empathetic to that, and you do want to be caring, and you do want to let someone know, I'm here for you. I'm here. I'm here. You can talk to me about anything. I'm going to listen to whatever you say, and I'm going to respect whatever you do. I mean, there's not much more I can say about that, except that we see hospice patients all the time. We only will see a hospice patient if they're not, so if they're on hospice for dementia, they have to come off, and we'll treat them because they are depressed. And knowing that you're actively dying is not easy for anyone. I think some people make their peace with things, but that doesn't mean that they're not sad about not seeing their family members anymore, or really having to make this journey. But you should let people know they're not making the journey by themselves. And it is okay to be sad at that point. There's nothing wrong with that. For family members, it's very important that they feel sad, because that's natural grieving. So at that point, we don't want to tell someone, you don't have to feel this way, or don't feel sad, because you should feel sad right then. Very different. That's a very, very different thing.
Yeah, those are really good points. And so what we try to do with our hospice support clients is help them process what they're doing by being a sounding board and make them listen to what they're saying. You can say it back to them, and they can kind of ponder that and maybe see something else and work their own way through that process at their own speed.
And we'll talk about some things to say and to not say in the next slide, but one of the very important things that kind of just struck something with me is you don't want to make anything sound better than it is if it's not better. You don't want to lie to people just to try to make them feel better, because that's not going to make anyone feel better. So helping people get a handle on what's going on with them, and letting them know that they can show emotion and they can feel emotion and they can be a sounding board, very, very important. And be genuine. That goes back to the compassionate and sensitive. If you don't really mean what you're saying, somebody's going to see right through that, and you're not doing anyone any favors, especially if it's with a family member and you say, you know what, Mom, I'm going to go to the hospital with you because, we're going to figure out what's going on. If you mean that, you're probably not going to have that kind of tone. And if you don't mean it and you're just throwing lip service out there, that's not going to make anyone feel like you really want them to get help. Like you really are concerned about what's going on with them every day. If you're just acting like you just want to get rid of him, you know what, that doesn't make anybody feel comfortable, or it doesn't have them trust you. This is a big deal. To talk to someone about how you're feeling mentally is a huge trust. You can't break that trust, and if you are in the position to break it, pass it on to somebody else who can do it. So things to say and things to not say. I will guarantee, and everybody in this room has said one of these things you should not say to anyone who's been depressed or sad. You have so much to be happy about. Well, do you? If you're depressed, you can't think of one thing you have to be happy about. So me telling you, you have so much to be happy about, you're probably struggling to figure out what that is. And I can list all the things I want, but that's not going to make you any happier. Go back to Robin Williams. He had so much to be happy about, but then he wasn't happy at the end of the day. You can get through this. You're so strong. I can be as strong as anyone. That doesn't mean I'm going to get myself through depression. I'm not going to just pull myself out of it, no matter how physically or mentally strong I am. That doesn't even make sense. I know how you feel. Do you? Do you know how anyone feels about anything? Not really. I mean, if you say you do, you don't. We don't know. We might know people that are very close to us. We might know what their emotions and their feelings tend to be, but we don't know how they feel. I could walk into the doctor's office, I could walk into the ER and have a broken arm, and I might be at that point ready to kill myself. You don't know that. You don't know what's going on with me. And because you're sad or you felt sad before, you don't know if I'm just sad or if I am truly clinically depressed. How are you? There's the magic question we've all asked. How are you? How are you? Fine, right? When we go to the grocery store, what do we say to the teller? Or he says, how are you? Oh, I'm fine. How are you? We don't even, that's not even an actual question anymore. Do we really care? After giving this presentation as often as I do, I care. So I try to look people in the eye when I ask, how are you today? When I came in and I asked, how are you today? You guys all blew that off. You know, we're here, we're having cookies. But I'm, you know, whatever. This chick's coming in to talk to us. She doesn't really care how we are, but I do. I do care how you are. And even though I think most everybody's going to say I'm okay, I'm going to put it out there that if you're not okay, I'm right here. I want to listen to it. And if you tell me, you know what, I'm not okay, I'm going to find out why, or I'm going to be there for you to talk to. I don't care who you are. If you tell me that, well, you know what, I've had better days. Well, I'm not just going to be like, oh, well, okay, I hope it gets better, you know. I'm going to want to hear and listen and talk. Think about that next time you go somewhere and someone asks you how you are. Yeah, I'm fine. How are you? And then you're walking off as you leave. How are you today?
Really?
Yeah, how are you doing today?
I'm just dandy.
Ask me how I am.
How are you?
I'm really great today. How are you?
I could be better.
Oh, all right. But I'm not saying, you know, well, yeah, how are you? And walking off, like a lot of times we do that. So let's change things today, even if it's in this room, let's change that one thing of how we do that. Just look on the bright side, and you're not trying hard enough. I don't know about you, but I'd be very angry if someone told me that I wasn't trying hard enough. Well, I'm trying to get out of bed every day. If I can make it out of bed, that's a big deal. So I'm trying not to lose my mind, and I'm trying not to cry every single time I open my mouth. So how do you know that I'm not trying? I'm trying very hard. I have to give this discussion to my own employees because oftentimes, even because they are representatives of Haven, they'll get some very interesting conversations out, like in the grocery store or at the gym. And we'll have people that come up, and I know that they're feeling my employees out, but they're not necessarily, they're salespeople, and so they're picking up on some cues, but not all of them. So we had a gentleman come up in the grocery store when we were getting some items to take out, and he said, so you work in the loony bin? Well, we don't call it that anymore, sir. So, you know, how old do you have to be? Well, you know, we see patients like 50 and up. Well, I think I might be sad, and I don't know, I'm kind of tired, I'm pretty cranky all the time. And one of my marketing people said, well, we kind of just take people that, you know, are a danger to themselves or dangerous to others. I could have just slapped her right there because we don't know what this guy, he's just feeling us out. We can't tell him we know how he feels, or, you know, his issues aren't big enough for us to even be concerned about, because we don't know that for a fact. So this is terrible. This is terrible. Those are all, don't ever say those things. The right things to say. Let me be strong for you right now. And we can use that across the board with anyone, and especially with your hospice clients. You know what? Let me be strong right now for you. You break down, you cry, you're angry, you can do whatever you want, and I'm going to be the strong one, and right now you just let yourself do what you need to do. I want you to know that I care about you. That is huge. When's the last time someone told you that? When? When's the last time someone said, I want you to know I care about you, and you're very important in my life? It's very powerful.
Mm-hmm.
It's very powerful.
You don't hear that often.
You don't hear that often enough. When I was putting this together, one of my friends had, the week before, we'd been talking about our patients and how they don't get touched enough.
Mm-hmm.
And how touch is very important, even if it's a touch on the hand. And so we started thinking, you know, that's a really simple thing, but it's a big deal. And then a couple of days had passed, and she called me and she said, you know what? I just really wanted you to know that I care about you, And having you in my life is really nice. And I was like, whoa, that stuck with me. It's like, that is the nicest thing. And to have someone say that and to know that they mean it makes me feel very worthwhile. So even if I'm feeling very sad and someone comes and tells me that, I know that one person thinks I'm worthwhile, even if I don't. One person cares about me. I've experienced depression before. That's a very, very different thing than I know how you feel or I know what you're going through. Explaining that you've gone through depression before can help someone feel a little more courageous about talking about what they're going through. Maybe there's, if you've gone through it before, it can't be that unusual. So saying, you know what, I have gone through depression before. I'm here if you want to talk. Don't say, yeah, I know exactly what you're going through, because you don't, because everyone goes through it differently. But I've experienced some of these things. You know, I'm able to talk to you if you want. Let me know. I admire your courage. I mentioned this before. Telling someone that you have mental illness is probably the bravest thing that's ever going to come out of your mouth. And to have someone tell you that in confidence is a big compliment to you, because that means that they trust you implicitly and they feel safe with you. Safe is a big word. If I'm going to open up to you and tell you my deepest, darkest fear about myself and the thing that I don't want anyone else to know and the thing that makes me feel the worst, I trust you and I feel safe with you. I'm going to call you tonight at 8 p.m. I'm going to call you tomorrow morning at 8 p.m. I'm going to call you today at noon. Why would that make any difference?
Give them something to look forward to.
That's right. If by chance I'm thinking about hurting myself, this is a twofold. Number one, I know you're going to call, so I know, you know what, I have something to look forward to. Miles is going to call me. I really want to chat with him. He makes me feel good, so I'm going to give him a call. Or I'm going to think, you know what, I'm not going to do anything at 8, because if someone calls and there's something not going on with me, well, I'm out. It's cat's out of the bag.
They're checking up on me.
That's right. It's a tricky way of checking up with someone, but also giving them someone to look forward to. I know I'm going to get a call at 8, and I'm really looking forward to that. And then I know I'm probably going to get a call at around midnight too. You know, just looking forward to that. Even if it's you call and tell someone a joke, even if it's the most ridiculous phone call, the fact that you picked up the phone and they're going to pick up the phone too, and they know that you care enough to give them a call, it's going to start being something, you know what, I'm really looking forward to that 2-hour call because this is so ridiculous, but I love it. And then you feel good because you're checking in just to make sure everything's okay. I'd like to help you. Now, I think we all do this, and we do it, and it comes from a good place. What can I do for you? Like if you're sick, if you've had surgery, if you're laid up, or your clients and you come in, well, what can I do for you today? I'll be honest, if I'm depressed, I don't know what you can do for me. I don't know. But you know what you can do for me. You look around my house, or you know me well enough, you know that you could, you know what I'm going to do? I'm going to go out and I'm going to weed your garden today. Because I know you probably are not, I'm not going to tell you that, but I know that's something that's important to you and you would like to do it. And if you're not doing it, I'm going to go do it for you. So pick out something. I'm going to bake cookies today. I'm going to do your hair today. I'm going to brush your hair. I'm going to do something nice today, but just you determine what that is. You don't make that person figure out what it is that you're going to do to make them feel better. And that's very different than having somebody make a list and have a goal. It's just you're offering to help and you're choosing something to do. The most important thing ever, and we don't like to say it because I think sometimes it feels silly to say to someone, or you don't want to be over dramatic, but telling someone not to kill themselves is very powerful. Because if you weren't thinking about it and somebody says that to you, well, now you think, you know what? Somebody knows I'm not feeling well and I'm not going to kill myself. And if you were thinking about it, then you're more likely to think, wow, that's pretty serious. Hearing those words come out of my mouth to you, don't kill yourself. That's pretty serious stuff.
You're not planting an idea in their head if they haven't been thinking about it.
No.
One thing I'd like to add is one more bullet point is, if you think someone's thinking about hurting themselves, ask them, are you thinking about hurting yourself? Are you thinking about killing yourself? Because I guarantee you, like you said, they're not gonna go, that's a good idea, I
Yeah.
hadn't thought about that before. You're not gonna plant the idea in their head, but then you'll have information that you can act on.
Exactly. That's the first thing we ask when people call for an intake call for us. They'll start saying, well, you know, I'm kind of sad, or I don't like this, or I don't like that, or this is what's going on. And our number one question is, do you feel safe? Do you feel safe right now? Are you going to hurt yourself? Are you going to hurt anyone else? Without hesitation. And you should not hesitate to ask that question either. And if someone says yes, you do not leave that patient. You do not leave that client. You make a phone call to 911 if that's appropriate. You do whatever. I don't know if you have a care counselor or you make that phone call, but you do not leave that patient. And I don't even care if they're joking. If they've been experiencing some symptoms and then they laugh it off and be like, yeah, well, I'm going to kill myself. I take that very serious, because oftentimes they have mixed emotions. They have inappropriate emotions. They laugh when they're scared. They cry when they're happy. So someone who laughs it off doesn't necessarily mean that it's a big joke to them. It means that's how they're showing emotion.
What if they lie to you and say no? And you know
People
they're
lie,
lying?
then you know they're lying. So what are you going to do in that case? Are you just going to be like, okay?
I don't know, that's what I'm saying.
And I'm asking, what would you do in that case? If you know that I'm depressed and you're with me and you think that maybe I look like I might be doing something to hurt myself, or I've maybe done some passive things to hurt myself, and you ask me and I tell you no, what would you do?
Not sure.
Well, you always want to be safe, rather safe than sorry. You don't want them to hurt themselves.
You don't want
Even
to.
if you're not-
Other than calling outside help, I mean, you can say these things, but get the person to talk about it, I imagine would be the best.
So you could ask some questions. I notice you haven't been taking your medications, or I notice you haven't been doing this. I notice you haven't wanted to go out, or I noticed this, or I noticed that, or I noticed that you seem to be really sad all the time. And then start asking, are you sad? Well, that you've done this, this, and this, and it makes me think that you might be feeling sad. Start that dialogue. You can't immediately just say, I know you're suicidal. You just have to start the dialogue, and so there's some logical conversation going on back and forth where someone says, you know what, I am doing things a little bit differently, and you know it. Opening that safety area.
One of the things I have to say is that the reason I asked you to come do this, I know you're an expert in this, but we got a call from one of our caregivers a couple of months ago about one of our clients. They were concerned that they were depressed. They noticed that all of a sudden, instead of one gun, he had 7 guns that he was cleaning and asked to be left alone. And so Shannon and I said, we need to go ask him if he feels like he wants to hurt himself and make an appointment with his doctor. And he does want to hurt himself, we need to intervene instantly. She suggested we should have some training on geriatric depression, and we've never done it before. So thank you so much for coming.
Yeah, absolutely. Absolutely. I know we're a little out of time, but I'm going to leave information for you, and you guys can call me anytime, and I'm very serious about that. If you call the hospital, we have an intake line, and that's for anyone to call. You don't have to just be a geriatric. You can call it even if you need information. And the last thing I want to bring up is everyone in this room is twice as likely to experience depression than someone else who's not caring for anyone. Twice as likely, because caregivers give of themselves more than they get for themselves. You're codependent. Nobody likes to hear that, but if you're a caregiver, you're codependent. You're often last on the list for things. Make sure that you have some time for yourself, and that if you are feeling these things, that you have a buddy, you have someone that you can talk to safely and quietly about whatever it is. Have one person available, and I stress that for caregivers because, again, we don't talk to a lot of people. Find one person you can talk to and let them know where you are. I'm feeling sad. I'm feeling anxious. I'm feeling overwhelmed. So you guys can have that dialogue. Because if you aren't there to take care of people, somebody else will do it, but you have to take care of yourself first. So thank you. Thank you all for having me. My pleasure.
Meaning that you practice, you said you do body language,
Mm-hmm,
to read body language.
mm-hmm.
Can you pick up on certain things being that you've worked with so many depressed?
Oh, yeah. I can walk into a room like this, and oftentimes if I'm walking in and it's client-based, so if I'm walking in with patients or I'm walking into a facility, I can I can often pick out just by expression and body language who's either experiencing depression or who's going through, who knows a loved one. So that, I don't know where that comes from, but that's what I have and that's what I can do.
That's great.
Which oftentimes when I leave things like this, I'll have someone come and grab me afterward, which is fantastic if it happens, but that's why I do these. Yeah, that's a great question. Do you guys have any other questions? Anything? No? All right, thank
Thank you,
you
Leah.
so much for having me.
Thank you very
Thanks.
much.